Welcome back. This is a part B of acute kidney injury. So I'm going to discuss the value of biomarkers in diagnosis. I'll present some special cases from the literatures, and I'll discuss in brief the 2012 KDU guidelines, and I'll end by some research initiatives done in Mansoura University. So starting with biomarkers, traditional biomarkers of acute kidney injury, including creatinine and urea, don't detect injury early enough, and this is the main problem in the diagnosis of acute kidney injury. This table summarizes the different biomarkers used in diagnosis of acute kidney injury. They may be urinary tubular enzymes that is released in tubular injury, urinary low molecular weight proteins like beta-2 microglobulin, urinary inflammatory molecules like interleukin 18, proximal tubular ischemic response, KM1 and NGAL, neutrophil gelatinase associated lipocalin, or other molecules or biomarkers. These are quite exhaustive list of biomarkers that may help in diagnosis of acute kidney injury. Regarding NGAL, which is neutrophil gelatinase associated lipocalin, its utility in diagnosis of acute kidney injury was discussed in many articles, and here, if you look, the area under curve is very broad of the level of NGAL in the serum plasma. NGAL is exceeding 155, so it is valuable in diagnosis of early diagnosis of acute kidney injury. And the situation, if we have positive NGAL and the creatinine is normal, this situation where we can say that NGAL is positive and the creatinine is negative, and if the NGAL is normal and creatinine is normal, this is a special group, and if the creatinine is normal and NGAL is high, is another special group. The merely the positive NGAL, the higher the need for renal replacement therapy initiation, the higher in hospital mortality, the higher the need for renal replacement therapy initiation in hospital mortality, the higher ICU stay, and the higher the hospital stay per days. Slide shows the value of NGAL complements prognosis in patients without diagnostic creatinine increase. So we may have patient with normal creatinine and normal NGAL, or patient with normal creatinine and high NGAL. The merely the higher the NGAL, the higher the risk of renal replacement initiation and in hospital mortality, and this is the cost and the mortality linked with the high NGAL. Another biomarker is the urinary leak of interleukin 18. If you look at the different causes of acute kidney injury, acute necrosis, hepatorenal syndrome, or renal failure, you will find that in acute necrosis, the interleukin 18 in urine is significantly higher than hepatorenal syndrome or renal acute kidney injury. Serum cystatin C and urine cystatin C. Serum cystatin C appears to be a good marker in the prediction of acute kidney injury, whereas urinary cystatin C excretion has only moderate diagnostic value. We have our experience in serum cystatin C in diagnosing hepatorenal syndrome, and we find it a good marker for evaluation of glomerular filtration rate in hepatorenal syndrome. In comparison to serum creatinine, serum cystatin C is more sensitive, more specific, and more accurate. And we used in this study the isotope clearance as a gold standard for comparison regarding creatinine and cystatin C. Another clinical point which is very important is the presence of volume overload. We shouldn't keep the patient overloaded. We shouldn't leave the patient in a volume overload, because volume overload is a biomarker for mortality in patients with acute kidney injury or patients with chronic renal failure. So the SDMA, which is symmetrical dimethyl arginine, is an early marker of a change in glomerular filtration rate in after donor nephrectomy in live-related kidney donation. As you see in this curve, just after donor nephrectomy, the level of this marker increases after just a couple of hours and reaching a high peak. If this marker will work in the patient with acute kidney injury, we don't know. So we are waiting further validation in other studies. In the pre-renal acute kidney injury, we may have the value for some acute kidney injury biomarkers like serum cystatin C, interleukin 18 in urine, or chem molecule. However, as you see here, the p-value is significant for all these three markers, but negative is not significant for NGAL or the GGT enzyme. So some biomarker increases with pre-renal acute kidney injury also. Regarding the biomarker, we can do this 2 by 2 squares, either creatinine positive, biomarker positive, this is verify correlation between biomarker level and acute kidney injury and confirm higher risk for additional outcome. If we have biomarker positive and serum creatinine negative, this is a false negative creatinine, because biomarker is more sensitive and specific for acute kidney injury, and the creatinine take time to be elevated. If creatinine is positive and the biomarker is negative, this means this false positive increase of creatinine, and we know the pre-renal factors or antibiotics that may increase serum creatinine. If we have biomarker negative and serum creatinine negative, this is true negative. So combination of serum creatinine and the biomarker may improve the appearance and of the diagnosis of acute kidney injury. And even the concept of renal angina, it was thought by this article that we may assess the patient by signs and symptoms in conjunction with risk factor of acute kidney injury and real-time GFR measurement. So this is just in the future we are dreaming if we can know the blood volume simultaneously and with proper and optimum utilization of biomarkers. In this following sector, I'll present some special cases. So if I start by this case, a 26-year-old male patient who has lymphoma treated with chemotherapy and shortly has elevated serum creatinine 2.5, potassium 6.5, uric acid 11, phosphorus 8, and normal renal ultrasound. So this is acute kidney injury. And from the history, this is a patient with lymphoma that was treated with chemotherapy leading to tumor lysis syndrome. So if we are dealing with lymphoma or leukemia, we should optimize the management of serum uric acid by good hydrations and use of allopurinol before chemotherapy. Or if there is high uric acid, we can use recombinant uricase therapy that decreases uric acid tremendously. Another case scenario is a 70-year-old male patient with retention and serum creatinine 4, ultrasound reveal moderate hydronephrosis bilaterally. So this is a classic history of patient with senile prostatic enlargement or prostate enlargement, and this is we can treat him initially by putting catheter and draining the kidneys and dealing with the etiology, either medical or surgical. Another case scenario, after indulging in a dancing session, Mrs. X developed oliguria and urine dipstick revealed blood and no cells by microscopic examination. This is a notice of rhabdomyolysis or hemoglobinuria. So in hemoglobinuria or myoglobinuria, you will find by dipstick positive blood, but with microscopic examination, you will never see cells. So serum creatinine rose to 3 milligram per deciliter and normal ultrasound, so this is a clue. History, vigorous exercise, plus presence of blood by dipstick and absence of red cell by microscopy. This is a case of rhabdomyolysis, and I can be sure by requesting the CK enzyme, and you'll find it very high. If serum creatinine increases after 2 weeks of selective angiography, we should think of acute renal disease, because if it is contrast-induced acute kidney injury, as I mentioned in this in the presentation of contrast-induced acute kidney injury, it occurs within 48 hours to maximum 5 days or even 1 week. But if the rise of creatinine occurs after 2 weeks of any maneuvers, this may reflect the occurrence of cholesterol emboli that is detached from the atheroma, leading to acute renal disease. Another important hot issue in acute kidney injury is intra-abdominal hypertension associated acute kidney injury or abdominal compartmental syndrome. And the increased intra-abdominal pressure can affect cerebral circulation, can affect kidney circulation, leading to acute kidney injury as presented in this slide. How to treat patients with increased intra-abdominal pressure and acute kidney injury? by improving abdominal wall compliance, evacuate the abdominal fluid collection, evacuate intra-luminal contents, correct positive fluid restoration, positive fluid balance, organ support, and the reduction of capillary leak as enumerated in this slide. Another scenario, this is a case, as you see, a case of chronic kidney disease, diabetic cholesterol lymph nodules, interstitial fibrosis, so diabetic chronic kidney disease, and renal tubule showed this is black stained by Vancosa stain, so this is phosphate inside the renal tubules, so this is acute phosphate nephropathy on top of chronic kidney disease, and it was confronted when the preparation of colonoscopy was by oral sodium phosphate. And to pick it up, we should look at serum phosphorus, because phosphorus increases after the use of oral sodium phosphate. Regarding sodium phosphate enema, the notion was that the phosphate present in this enema is not absorbed, so it works locally as osmotic, but the studies showed that sodium phosphate enema may lead to fatalities and metabolic disorders, as was published this year. So this study included 11 patients from the geriatric age group, 6 women and 5 men. The age is 80 years. The estimated GFR for patient, the estimated GFR above 60, and 7 patients from 25 to 57 ml per minute. The enema dose in 3 patients from 500 to 800 ml, and in 8 patients just 250 ml. The complications encountered in this study were hypotension and volume depletion, hyperphosphatemia, hypocalcemia, and hypokalemia. All the patients had acute renal failure. 2 patients necessitated urgent hemodialysis, 5 deaths, and prolonged hospitalization for 3 of the 6 survivors. So the conclusion, any elderly patient with an atonic bowel for whatever reason and a reduced glomerular filtration rate should not receive phosphate-containing enema, because it may be complicated with acute phosphate nephropathy. If you have a patient who has prolonged fever, and after giving the patient the antibiotics, think of the rare etiologies, because this is the dogma. If we want to be a good physician, we should put in our agenda the most common causes of the situation and the most serious and the fatal causes. And one of the most serious and the fatal causes is systemic zygomycosis and renal zygomycosis. This is the CT showing the globular pattern of the kidneys with poor perfusion of the kidney, and this is a sign with magnetic resonance imaging. And after exploration of the patient in this scenario, they found a lot of necrosis and evacuated the kidneys with some of the viscera, and the patient died at the end with sepsis, and the kidney biopsy revealed the evidence of fungi. So this case reflects the need of multidisciplinary team approach, the necessity of cooperation between physician, radiologist, and nephrologist in diagnosis of the patients. One of the important questions in this presentation, does AKI lead to chronic kidney disease? The answer from this study that was published in the last June in the Journal of American Society of Nephrology is that the authors are trying to put explanation, because 500,000 of the patients per year have acute kidney injury, and the minority develop chronic kidney disease. So they concluded at the end of this paper that acute kidney injury is guilty only by association, not causation. And they put a model, either risk factors like diabetes or etc. lead to both acute kidney injury or chronic kidney disease, or the model, the patient with chronic kidney disease develop acute kidney injury, or the risk factor lead to acute kidney injury and followed by chronic kidney disease. So this is the models extrapolated from this study. However, the editorial comment said that it is yes and yes, acute kidney injury truly leads to chronic kidney disease. And from this study, targeted proximal tubular injury triggers interstitial fibrosis and glomerulosclerosis. So this study showed that there is an evidence for the reflection of acute tubular injury on the CKD causation, as evidence here. If you make repeated injury you will find the fibrosis, a lot of fibrosis. And this is the editorial arteriotubular cell, not only victim, but also perpetuator. And this is the editorial comment stating that are tubular cells not only victims, but also perpetrators in renal fibrosis? And the answer is yes, it can lead to fibrosis. Through this model, repeated acute kidney injury lead to tubular damage and tubular repair, leading to recruitment of inflammatory cells, increasing cytokines and mediators, leading at the end of the tubular atrophy, interstitial fibrosis, glomerulosclerosis, and chronic kidney disease. So there is a link between acute kidney injury and the occurrence of chronic kidney disease. The summary of KDIGO guideline of this year regarding the evaluation and general management. The guidelines recommend the evaluation of the patient with acute kidney injury promptly to determine the cause with special attention to reversible etiology. To monitor patients with acute kidney injury with measurements of serum creatinine and urine output to stage the severity according to recommendations. To manage the patients with acute kidney injury according to the stage and the cause, and to evaluate patient 3 months after acute kidney injury for resolution, new onset or worsening of pre-existing chronic kidney disease. And these are the different lines of management from discontinuing all nephrotoxic agents. It's very important to be tackled, ensure the volume, and consider functional hemodynamic monitoring, monitor serum creatinine and urine output, avoid hyperglycemia, consider alternative to radiocontrast procedures using non-invasive diagnostic workup, consider invasive diagnostic workup, and up to the end of the algorithm. Regarding fluid therapy, the question is, which is the best to be given to the patient, colloid or crystalloid? In the absence of hemorrhagic shock, because in hemorrhagic shock, it's better to give the patient blood. We suggest using, this is a recommendation, suggestion of the use of isotonic crystalloid, like isotonic saline, rather than colloids, albumin, or starch, because albumin or starch are more expensive and with more side effects, and they don't improve the patient outcome, and even starch may lead to starch-related nephropathy. So the recommendation is, in the absence of hemorrhagic shock, the recommendation suggests using isotonic crystalloid rather than colloid as initial management for expansion of intravascular volume in patients at risk for acute kidney injury or with acute kidney injury. Using the proper usage of vasopressor when it is indicated in treatment of septic shock. So the guidelines recommend the use of vasopressors in conjunction with fluids in patients with vasomotor shock with or at risk of acute kidney injury. Regarding the glycemic control and nutritional status of the patients on acute kidney injury, in critically ill patients, the guidelines suggest insulin therapy targeting plasma glucose between 110 to 149 and to avoid hypoglycemia. And they suggest achieving a total energy intake of 20 to 30 kilogram per kg in patients with any stage of acute kidney injury. And the guidelines suggest as well to avoid restriction of protein intake with the aim of preventing or delaying initiation of renal replacement therapy. And they suggested administering from 0.8 to 1 gram per kg per day of protein in non-catabolic AKI, patients without need for dialysis, increasing this protein intake to 1 to 1.5 in patients with AKI on renal replacement therapy, and up to maximum 1.7 gram per kg per day in patients on continuous renal replacement therapy and in hypercatabolic patients. And also suggesting providing nutrition preferentially via the intra-route, so oral supplementation or oral intake of diets is superior to parenteral diet. Regarding diuretics, they recommended not using diuretic to prevent acute kidney injury, and just suggesting using diuretic to treat volume overload when it is necessary. Regarding dopamine, phenolidipam, and in atrial natriuretic peptide, they recommended not using either of dopamine or phenolidipam or atrial natriuretic peptide in treating acute kidney injury. They don't recommend using recombinant human insulin growth factor 1 to prevent or to treat acute kidney injury. Regarding the usage of aminoglycosides, and this is one of the preventive method, we don't like non-steroidal, we don't like aminoglycosides because we are concerned with their relation with acute kidney injury. So the kidney guidelines suggested not using aminoglycosides for treatment of infections unless no suitable, less nephrotoxic therapeutic alternatives are available. And they suggested that in patients with normal kidney function, in a steady state, aminoglycosides are administered as a single dose daily rather than multiple dose daily treatment regimens. And they recommended monitoring of aminoglycoside drug levels when treatment with multiple daily dosing is used for more than 24 hours. And they suggest monitoring the aminoglycoside drug levels when treatment with single daily dosing is used for more than 48 hours. Regarding amphotericin B, they suggested using a lipid formulation of amphotericin B rather than conventional formulation of amphotericin B. In the treatment of systemic mycosis or parasitic infection, they recommend using azole antifungal agents and or the echinocandins rather than conventional amphotericin B if equal therapeutic efficacy can be assumed. Regarding the renal replacement therapy initiation, initiate renal replacement therapy emergently when life-threatening changes in fluid electrolytes and acid-base balance exist. And we agree with that. Consider the broader clinical context, the presence of conditions that can be modified with renal replacement therapy, and the trends of laboratory tests rather than single blood urine nitrogen and creatinine thresholds alone when making the decision to start renal replacement therapy. Discontinue renal replacement therapy when it is no longer required, either because intrinsic kidney function has recovered or the patient doesn't need the renal replacement therapy. We suggest, the guidelines suggested not using diuretics to enhance kidney function recovery or to reduce the duration or frequency of renal replacement therapy. They suggest initiating renal replacement therapy in patients with AKI via an uncuffed, non-tunneled dialysis catheter rather than a tunneled catheters. And when selecting the vein for insertion of a dialysis catheter in patients with AKI, consider these preferences. First choice, right internal jugular vein. Second choice is femoral vein. Third choice, left jugular vein. And last choice, subclavian vein, with preference for the dominant side. And they suggested to use dialyzer with biocompatible membrane for intermittent hemodialysis and continuous renal replacement therapy in patients with acute kidney injury. So these slides summarize the different dialysis modalities that may be used in managing the patient with acute kidney injury. And the modalities are either intermittent hemodialysis, continuous renal replacement therapy, or slow, low-efficiency dialysis, or peritoneal dialysis. And this is regarding intermittent hemodialysis. It is the potential setting in acute kidney injury for patient with hemodynamic stability. So it is fitting for the patient with good blood pressure. And the continuous renal replacement therapy is for the patient with hemodynamic instability or the patient at risk of increased intracranial pressure. SLED is suitable for patient with hemodynamic instability, and the peritoneal dialysis is suitable for hemodynamic unstable or the patient with coagulopathy or difficult to access regarding the vascular system. So these are the potential setting for different modalities in acute kidney injury. The advantages of intermittent hemodialysis is rapid removal of toxin, allow for downtime for diagnostic and therapeutic procedures. The advantage for chronic renal replacement therapy is continuous removal of toxin and hemodynamic stability. The advantages of SLED is slower volume and solute removal and keeping the hemodynamic stability. And the advantage of peritoneal dialysis is simple in technique and hemodynamic stability and the need of no anticoagulation. Regarding the disadvantages of intermittent hemodialysis is the occurrence of hypotension with rapid volume removal, dialysis disequilibrium, and technically more complex and demanding. Regarding the disadvantages of chronic renal replacement therapy, slower clearance of toxins, need for prolonged anticoagulations, patient's immobilization, and increasing cost and hypothermia. And the disadvantages of SLED is slower clearance of toxins and technically more complex and demanding. Regarding peritoneal dialysis, poor clearance in hypercatabolic patients and protein loss, no control of rate of fluid removal, risk of peritonitis, hyperglycemia, and requires intact peritoneal cavity, impaired diaphragmatic movement, potential for respiratory problem. So these are the different modalities, their indication, the advantages and disadvantages of each type of modality. Regarding the dialysis modality, they suggested using CRRT, continuous renal replacement therapy, rather than standard intermittent renal replacement therapy for hemodynamically unstable patients, as I mentioned before. And they suggested also using CRRT rather than intermittent RRT for acute kidney injury patients with acute brain injury or other causes of increased intracranial pressure or generalized brain edema. Regarding the dose of renal replacement therapy to be delivered should be prescribed before starting each session of renal replacement therapy, and they recommended frequent assessment of the actual delivered dose in order to adjust the prescription and to provide RRT to achieve the goal of electrolyte, acid base, solute, and the fluid balance that will meet the patient's need. And they recommended delivering Acute overview of 3.9 per week when using intermittent or extended renal replacement therapy in acute kidney injury, and this is of high evidence. And they recommended delivering an effluent volume of 20 to 25 ml per kg per hour for CRRT, and this will usually require a higher prescription of effluent volume. This is one of the most ugly slides because it showed that the mortality doesn't change through the decades of acute kidney injury. The column reflects the mortality for the certain time period, and this line reflects the number of patients in each study. So the mortality is ranging from 40% to 57%. So although there are advancements in the diagnosis and all facilities and in the medicine in general, mortality is still high in patients with acute kidney injury. For my mind, the only way to improve the outcome of acute kidney injury is knowing the philosophy and the critical relation of acute kidney injury with other systems. Because acute kidney injury is not isolated renal defect, it affects other systems in the what is known as kidney other system crosstalks. So this is so the only thing that will change the map and change the outcome of acute kidney injury is development of proper research in this field. And this is what we had in the Mansoura Medical Experimental Research Center, and this is the medical student experiment using clamp to make the acute kidney injury model. You can compare this kidney with ischemia injury, and this is a kidney without ischemia injury, and this is one of the medical students, and this is one of the poster that was presented in the Amsterdam conference, and this discussed an important issue if the gender does affect the acute kidney injury, because these students observed that the acute kidney injury in patients, in female patients, is less severe than male patients, so they make the experiment and prove that theory. And win the session winner for nephrology in the Amsterdam conference. These are two students who have their paper on the acute kidney injury and the brain crosstalk, and they found that toll-like receptor 4 is expressed in the glial system, and their poster was presented in ERA Edita in this year under toll-like receptor 4, a Trojan horse of acute injury-induced encephalopathy. And these other two students who have their paper that was also presented as poster in the ERA Edita, and they use mesenchymal stem cell to ameliorate septic acute kidney injury model. So the proper research using the young generation change the outcome of acute kidney injury. Thank you for attention.